So tonight we're going to break from tradition and we're going to do our photos of the day after Charlie's presentation. So we've got some absolute rippers in there. We don't want everyone getting too excited prior to Charlie's presentation, so get excited for them to be at the end of the session tonight. Quick reminder before I forget, with tonight, Pirate Man, 7:30 it kicks off. There'll be 2 hours of drinks there. It's quite a small space, so leave as many large items or valuables at home if you can. It is, however, a 200-metre walk outside, so make sure you do have something warm to put on. There are no food options there, so also ensure that you've got something to eat before you head there. I think, was there anything else for Pirate Man? Pardon? Oh yeah, and no valuables, no passports. It's happened a number of times before, but no passports, you've been warned. Is it cash only? It is cash only, yes, yep, cash only from 9:30 and the exclusive use till midnight. So, let's, we've had 7 amazing presentations, we've got 1 more to go, so let's give a huge round of applause to Charlie.
Thank you all very much. I hope you've had a great week, and thank you, Dylan. Thank you, Quinton. It's been fantastic. Thank you, Cody, for making me really relax before I stand up here before everyone. It's not my usual state of affairs. I'm an emergency physician from Brisbane, and I'm going to talk through a case of massive pulmonary embolism tonight, and just run through a few things, basically how it can present, not how it always presents, how you can diagnose it, and then the management with particular, I guess, concentration upon a remote setting. Because when we're sitting in a tertiary ED, we're surrounded by other professionals, people that are really clever, people we can call on to come and give us a hand. But when you're out in a small country town, you don't have that, and that makes life interesting. So about 10 years ago, I was in Brisbane. I'd done about 3 years at a big tertiary hospital in the Prince Charles Hospital. My wife was working for a company called International SOS. We had 2 kids, we had a house, we had a mortgage, and we realised that if we weren't careful, we would be there in 15 years' time when the kids left home, and that would have been exactly the same. We're itinerants. We like moving. We like change. We probably have ADHD. So we decided that we were going to mix things up, and I decided that I would get a job in Beijing as an emergency physician in an expat hospital. But that didn't quite work out because my primary medical degree is from the UK, as you can tell from my accent. But I've trained as an Australasian emergency physician, and that was something that was impossible to explain to the Beijing Medical Board, the Chinese Medical Board. And so I didn't get a job in Beijing. My wife got a job in Beijing, and I became something that's called a trailing spouse. And that's about as fun as it sounds. So there we are. That's my lovely wife, Jackie, my 2 boys, aged 5 and 6, when we left on our adventure. And we had a great time. I mean, it was a really interesting experience. We wanted to go and get the children to learn Mandarin. We thought that would be, fantastic, getting, your children fluent in Mandarin. And they turned into a couple of little hippies, as you can see. And then after about 3.5 years, having learnt no Mandarin, we went to Singapore for a couple of years, and that's Angus there, my oldest boy, having to lose his hair, because you can't have long hair in Singapore if you're going to go to school. So he was really sad. And actually, back in Beijing, after about 6 months, I was really sad as well. I hadn't understood just how much of my self-worth and identity was tied up with being a doctor. I loved being a stay-at-home dad. It was great. But I think I got a bit depressed. And so I looked around for something to do. And at that time, the resource boom was on full swing in Western Australia, and they were paying silly money, something called royalties for regions. I don't know if you remember that. So I could fly back for about 10 days, all the way from Beijing to rural Western Australia, work, and then go back home, and the cost of the flight and everything, and I still came home with money, and I had a good time, and I was doing something that I liked doing again. So that's what I started doing. And I worked predominantly in 3 areas, one in Karratha, up the top of WA, one in Geraldton, where this case unfolded, and the other in Kalgoorlie. Now, hopping on the plane in Beijing, in the middle of winter, it's like here, it's minus 15 degrees. So I would have my thermals, my jeans, big pair of boots, big down jacket, numerous jerseys, and stomp off to the airport at 5 o'clock in the morning. And I would get spat out in Karratha in 42 degrees. So it was entertaining. And Gero, I don't know if people know Gero at all. Well, there's a number of Western Australians here, I'm sure. It's a town of about 30,000 people. And it's home of the crayfish. And so there are lots of crayfish there. And there are lots of people that try and catch crayfish there. It's a smallish sort of hospital. It's about maybe 86 beds. There's a couple of surgeons, a couple of physicians. But you know, there's no ICU. In fact, that's your role as the emergency specialist. If something bad goes wrong, you're the crit care specialist. So it's fun. You know, I turn up to work at 10 o'clock in the morning. I go home, if I'm lucky, at 8 o'clock at night. But I'm the only face in there, and I'm on call 24 hours a day, and then I do it again the next day. So it's demanding, and sometimes you turn up and your staff skill mix ain't great, but sometimes it is great, and I was really lucky this day. Oh, sorry, that's me with the crayfish. I was really lucky this day when this case unfolded because I had a great staff mix. So here we are, this is WA, there's Perth down the bottom, and thanks to Google Maps, I can tell you that it takes 4 hours and 32 minutes to drive from Geraldton to Perth. But obviously if we have someone sick, then they've got to get transferred not by road but by air, and of course that's usually with RFDS. And RFDS did a fantastic job. They were always overworked, they were always trying to help, and sometimes we got frustrated with them because, you know, a lot of the time we'd have a psych patient that would sit around for 4 days because we had no psych in Geraldton. But when we had a sick patient, they were there. And so in normal transfers, they'd come, you know, they'd come into the hospital, we'd do a handover in the ED and then send them on their way. But if they were really sick, then we'd do a tarmac transfer. So we'd drive the ambulance out to the airport, and we would hand over in the shed or even on tarmac. And the airport's only about 10 minutes away from the town, so you can get in the truck, you can drive at some crazy speed because it's a really straight road, and you get there to the airport in 10 minutes. But the weird thing about Geraldton is that to get from the entrance to the airport to the RFDS shed took about another 5 minutes because there are 20 speed bumps and really harsh ones. So you could floor it and then you just be going ga-dung, 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 trying to get into it. It was incredibly frustrating. So this story starts with the tannoy, Dr. Tweed resus, which is never a good thing to hear. And a 19-year-old girl was sitting up in bed, and she was a ginge, a bit like me, but she was the whitest ginge I'd ever seen in my life. So some gingers have got, you know, that really dark ginger hair and are white, but she was the whitest person I think I've ever seen. And that's because she was incredibly unwell. She was shocked. She was obviously dyspneic from the end of the bed. You can see her chugging away. And she was thrashing. And that often happens when people are pretty shocked, right? They've got a bit of cerebral hypoxia and they're non-compliant. And that was all she was saying, can't breathe, taking the mask off. Now, at that point I was kind of starting to step into action. And then I realised that I'd seen this patient 3 days previously and discharged them. You can imagine what I thought then. So this is the initial reaction, and then I don't know if other people feel the same, but I actually, and it's not a good emotion to have, but you also think, oh fuck, I'm in really big trouble now. And it's kind of hard to get back from that. I want to take control. I'm the leader of the team, and mentally I'm struggling. So it was not a good start to this resus. So the background for this girl was that she had a condition called relapsing nephrotic syndrome. And that is something where you often, after post-streptococcal glomerulonephritis, you get this nephrotic syndrome, you end up losing loads of protein in your wee and you balloon out with loads of fluid everywhere. And this is exactly what she's had since the age of 6. And usually what happens is you get about 3 or 4 episodes and then it burns out in your early or mid-teens. But she's 19 and she's just had another relapse. And so 10 days previous to this presentation, she'd been down in Perth to see the renal team, and they were equally flummoxed as to why this would happen in a 19-year-old, and so they'd done a renal biopsy to find out what was really going on. And as part of their management, she'd been started on higher dose steroids and commenced on furosemide to try and get rid of some of this fluid. So why she'd come into the ED 3 days before was because that she was getting increasing peripheral edema. So her legs were tree trunks, she got swelling in her fingers, and they get it around their eyes as well. And she had this vague abdominal discomfort. And the thought was maybe this is related to her biopsy. I'm not sure if you can see that at the back, but that is a set of her vital signs, and they're all normal. So what would your diagnosis be? And I'm not going to ask for questions from the audience, but I was struggling. I don't know. Maybe she got worsening renal failure. Maybe she got a complication from her renal biopsy. Maybe there was something that was going on that I didn't understand, because I hate renal medicine and it's really, really tricky. So I did what I could think of, which was to do an ultrasound of her renal tract. And that looked normal, so there's no hematoma or complication from her biopsy. Her bloods were all normal, her renal function was okay. And then, like we do in emergency when we don't know what's going on, we phone someone cleverer than us, and I phoned the renal team in Perth, and they didn't know what was going on either. So they said, well, why don't you send her home and we'll do a teleconsult tomorrow. And that was a great idea. The problem was that I had been talking to the dad, who was incredibly nervous. I mean, obviously you would be, your 19-year-old beautiful daughter, multiple medical problems over a number of years, and now she's got another relapse. And it took some time for me to reassure him, and I tapped him on the shoulder, looked him in the eyes and said, don't worry, sir, I'll look after her. I'll keep her in hospital until we know what's going on. And then I sent her home. So that was bad, but the patient wanted to go home. So, she's an adult, she's 19. So if we return back to the bit where it's all going really, really wrong and I'm not doing very well at the moment, this patient did not arrive with the paramedics, by the way. This was a drop at the door. And by the way, all you paramedics out there, thank you so much for having a nicely packaged patient that arrives. Because when they turn up like this, being thrown out of the back of the car door, it's terrifying. She had been up feeding the horses. Dad was in the kitchen and watching her walk up to feed the horses, got to the horses with a bucket in hand, and then had just collapsed and hit the deck. Now, Dad came in saying, she's had a massive PE. They warned me about this. This is exactly what I had to watch out for. She's had a massive PE, which was really helpful, because I don't know if I'd have thought about it by myself. So what do we do now? Well, when an emergency doctor asks you what you're going to do with a really sick patient, fortunately it's really, really easy, because it's just back to the algorithm, right? A, B, C. And so, that mode flicks over. So we're going to do our ABCs, and we're going to get a line in. We're going to send off a bunch of blood tests because that's super easy. And oh yeah, we haven't got any vital signs yet because no one's actually doing anything at the moment. So we definitely need some of those. And we can put some oxygen on because she's short of breath. And here come the opposite. I can't believe it. I've got a bug crawling on the computer. Oh, sorry about that. So here are the vital signs. And again, let's just run through what they are. So that's the respiratory rate up the top there. That's 32. Like I'm doing now. So that's her respiratory rate. It's 32. That's her oxygen saturations, which is 89%. That's on room air. So not awful, but not great. Her heart rate is 85. And then there's this bad bit down the bottom, which is the blood pressure. And that's 43 on 36. Now, yes, that's not good, right? So I did a brief, primary survey examination, and she had a carotid pulse, but she did not have a brachial pulse, and she did not have a femoral pulse. And she was the coldest, whitest, iciest thing that I've ever examined. It was awful to look at her. Well, now what are you going to do? So, is this an A problem? Not really. She's breathing. Is it a B problem? A little bit at the moment, but mostly it's a C problem. And so that's where we directed our attention. So we bunged a second line in, and then we want to give her some fluids. And the difficulty here is how much are we going to give her? And I'll talk about that in a little bit more. But to start with, we gave her a 500 ml bolus of normal saline. The second thing is she's not, what it's a terrible term, nurseable, which means that they can't put the bloody monitors on. She's peeling the oxygen off. Nothing's actually staying on that we want to monitor the situation. So we've got to think about how we can control that. And usually we did that with sedation. Now, there are issues with sedation, as I'm sure you all know. Most sedatives, say midazolam, that you often use pre-hospital, or fentanyl, which I'm sure you're all familiar with, they lower blood pressure. And if we give any of that to her, she's going to die, right? So we chose to use ketamine. And ketamine can sometimes cause apnea. You can get a transient apnea. But we gave her tiny doses of ketamine, and we managed to get away with it so that we could actually keep the monitoring on. And then we're going to organise some investigations. And we think we've got a PE going on. We kind of have to make sure that we're not missing anything else. So we're going to run all our basic bloods. And so normally we would diagnose a PE with a CTPA or sometimes a VQ. Now, this patient is not going anywhere near a CTPA. So that's not going to happen. And the next thing we're going to do is think about making her blood pressure better. And so we want to give her some adrenaline. And so that was our first line up. We're going to set up adrenaline infusion. 2 nurses disappear to do that. We're going to crank that up. This is peripheral. Now, I promise this is the only difficult slide in the whole talk, but I'm sure we all learned years ago about the Frank-Starling curve. So, end diastolic pressure, x-axis, stroke volume, y-axis. You give increasing fluids here to increase the diastolic pressure, and then you get an increase in stroke volume, and therefore cardiac output, and therefore blood pressure. And so that's what we're going to try and do. All right. And so this works really well at this section of the curve. You get a little bit of fluid, a little bit of end diastolic pressure goes up, your stroke volume goes up, and then it stops working. You get this flat bit over here. And then if you've got too much volume going in here, or increasing the end diastolic pressure too much, you're on the failing bit here, right? So more fluid equals bad over here. Now, inotropes can make the whole curve go upwards, so we're doing that. But we were talking about fluids earlier and what we're meant to do. And so everyone's got this in their mind, but actually there are some subtle differences between the right ventricle and the left ventricle. So the left ventricle over here is forgiving. You can carry on giving a fair bit of fluid and things do go down, but it's not awful. The right ventricle, you give a bit of fluid, and if you're fluid overloaded, boom. So that's the death spiral of right heart failure. Now, with this patient, she's fluid overloaded totally because she's got all this fluid leaking out from her intravascular space. But intravascularly, she's been on furosemide. She could be a little bit volume depleted. And so we decided to give her a little bit more fluid, another 500 mils of normal saline. Now here's our first investigation back, and in the emergency department that's almost always a venous gas. And I don't know if I put the red buttons around this, the red things around this. No, I didn't, all right. So I'll just read it out again. The pH is 7.275, so she's a bit acidemic. The PCO2 is 65, and the reference range is top is 50. Now, it's not particularly accurate doing a venous gas looking into interpreting this PCO2, but we're going to suggest that probably it's a bit high. And the next thing to look at is the lactate, which is 2.9. So that's not too bad. I mean, that's going to be less than 1.5, but it's not shocking. Excuse the pun. And here's our progress with our management so far. So over time, we've got these inotropes cranking, we've got the adrenaline cranking, but yeah, the respiratory rate is 40, 48, 38, 32. The oxygen level is now starting to sneak down a bit, so that's going to go down to 93, 95, and that's on 100% non-rebreather, right? And down the bottom, the blood pressure is still unrecordable. So we've got to do something more, or a bit better, or different. So we've got to look at intubating her, I reckon, because she's going to get tired. And at the top of the bed was a South African doctor. Now, as you probably know, South African doctors are usually brilliant. They've got a lot of war stories that they can tell, and they're very good at doing things. But this South African doctor, this was his first day at Geraldton. The poor bastard. Now, intubating a person with no blood pressure is really dangerous. If you give a rapid sequence induction, they usually die. But we were lucky. We gave her a light anaesthetic with ketamine, and he got the tube in first time. The next thing that we can think about doing is giving her more pressors. So we've got an adrenaline infusion that we're just rapidly twisting up the buttons to get it going as fast as we can. But we add in some noradrenaline. So there's 2 syringe pump drivers going now, and that rapidly goes up. These are still peripheral. But we really kind of want to get our inotropes in centrally, so we're going to have to put a central line in her. And we're working on the diagnosis for PE, right, at the moment. And if she's this sick, we're probably going to thrombolize her. And if we stick a line in her neck, then she will get an expanding neck hematoma, and that would be bad. If we stick a line in her subclavian vein and we give a pneumothorax, that would be bad, and it's a non-compressible vessel. So in this situation, and pretty much for all flyouts, we put a femoral line in. But we want to get that femoral line a little bit lower than usual, because we want to compress it if we get a complication from our thrombolysis. And in the excitement, with the ultrasound, you know, the vessels twist around each other as they go a little bit lower. And we weren't terribly, one of my colleagues who was putting the lines in, very competent, but wasn't entirely sure which vessel he'd got which line in. And in the end, it didn't matter because the blood pressure in both of them was the same. It was 35. So her filling pressures in the venous system were as high as her arterial blood pressure. And what we want to do now is to get an echo. So she's never going to it for a CTPA. We've got to have a proper diagnosis. We think she's had a PE, but we've got to prove it before we've crossed that sort of threshold of the risk-benefit ratio of giving her her thrombolysis. And fortunately, one of the advanced trainees in medicine was good at echo. He loved it. I'm hopeless at echo. I can't do it at all. So it wasn't going to be me. It wasn't going to be anyone else in the emergency department. There's no cardiologists in town. But we were so lucky. So we phoned up Valentine and he came down very quickly and started doing his echo. And then, well, our resuscitation so far, we're thinking we've done all the things that we know how to do, but is there anything else we can do? So we start phoning around. And so RFDS have got to come and pick this patient up. And we started phoning ICU in our receiving hospital. Then the next blood gas came back. Sorry, I'm just going to have a little drink of wine. And so here we can see our acidosis, our acidemia is getting worse. That's 7.1 now. The PCO2 is over 100. This isn't going well at all. The next thing is the lactate has gone from, what was it, 2.1? Oopsie. Oh no, go back again. To 6.3. So unsurprisingly, she's getting a truckload of inotropes and she's shocked. Her lactate's going to spiral up very, very quickly. So a little word about echo now. Oh, that was loud. So this is a normal echo, and this is a long axis parasternal view. And let's just put go. So what we're looking at here, that's the right ventricle at the top, and it's quite small. This is the left ventricle here, and that's quite big. And really importantly, you can see how much bigger it gets during diastole, right? So it contracts, it gets quite small, and then it gets really, really big. And this is the short axis parasternal view. So what we've got here is the left ventricle here and the right ventricle here. So right ventricle big, filling during diastole. And the other thing to note here is something called the interventricular septum. So that's the bit of muscle between the left ventricle and the right ventricle. Left ventricle, much higher pressure system than the right ventricle, so it bulges this way up towards the right ventricle. And this is our patient. Oopsie. There we go. So just to compare, this is the right ventricle, which is a balloon. And this is the left ventricle, which is almost completely empty during systole and doesn't really expand very much at all during diastole. So just a diagram to explain that again. So with PE, we see this big blown out RV pushing into the left ventricle. And then on the short axis, you get what's called a D sign. So you get this D shape because the right ventricle pressure is now so high, it's starting to push the interventricular septum into the left ventricle. So that's called a D sign. It's basically pathognomonic. And if we look at our patient here, here's our big blown out right ventricle here, and there's our classic D shape in the left ventricle. And the clever ones amongst you will notice that actually this heart rhythm is not sinus anymore, it's irregular. So what is a massive PE? It's a massive PE is defined as an acute PE with sustained blood pressure less than 90 systolic. Well, that's us, tick. Requiring inotropic support, tick. Not due to another cause other than PE. Well, we're pretty sure about that, but we do have a slight arrhythmia. She's certainly not hypovolemic septic and doesn't have LV dysfunction. We don't have pulselessness, and we never got bradycardic. And then the treatment basically is a thrombolytic. So pretty much all of the studies have been done using TPA, and there are various algorithms out there and numerous different trials looking at one way versus another. But I'll just draw your attention to, oopsie, let's see if I can find If alteplase is unavailable, that's us in Geraldton, consider using streptokinase, which I haven't seen in 20 years, or tenecteplase. And that's what we've got, because we thrombolyse all our STEMIs out in Gero, right? We don't have a cath lab or anything like that. But we do have tenecteplase. Other little point, use the peripheral IV route. There's no point giving it via a central line. Before we give thrombolysis, we've got to start thinking about contraindications. And I won't run through all the list of contraindications, but one of them is this. So she'd had a fall and may have banged her head. So we had a quick look around there because we don't want to give her an intracerebral hematoma. But the other thing is, of course, she'd just come back from Perth and had a renal biopsy. And so that's a non-compressible puncture. So that's a kind of contraindication. But she's just dying, right? So we've got to try something. So we thrombolyzed her. We gave her a half dose of tenecteplase. There is evidence that the half dose is as effective, but with lower complication rate. This is a great slide from EM Crit. If anyone wants to look at thrombolysis in PE in more detail, I'd strongly recommend you go to EM Crit, have a look through. But basically, maybe we have a relative lytic contraindication. But we drop down here, and I think we are in the bad one in red down here, crashing massive PE. I think we've got all of that. Definitely give it. And we don't have an absolute contraindication. And even if we did, we don't have anything there that we can do. So we gave it. Did it work? So pH 6.8. So this is incompatible with life. Her PCO2 is now climbed to 110, lactate 7.4. And her vital signs, oh, hello, there we go. No blood pressure. So what would you do now? And this is a tricky question, but one of the things that I had been concentrating in down the bottom end was all our central lines and arc lines, and I hadn't really been up the top end to see how our poor South African doctor on his first day in Geraldton, first day in Australia, was going. And we should check the tube, right? So we've got poor gas exchange going on, and so we've got the chest X-ray, and of course he'd done a classic emergency department intubation in a stressful, exciting situation, right main bronchus. So we can pull that back, and that might work. That will give us a better gas exchange. We can check our ventilator settings, and yeah, look, he just left it on the default at 12. So we bumped that up to 20. And then the other thing is these vital signs here. So the heart rate's flicking up to 155, 160, and on that echo trace you can see, if you're really clever, that she's in atrial fibrillation. And that's because we're pumping so many inotropes into her that she's flipped into AF. So do you want to defibrillate her to put her back into sinus rhythm and create a better cardiac output? Well, my feeling on this one was very much no, because they get myocardial stunning after a defibrillation, and so we may have a transient episode of zero blood pressure, and then it's all over. You never get it back. We could give a bicarb. I mean, like a pH of 6.8, the LV or the heart is not going to function. At that pH, it just doesn't function. So giving a bolus of bicarb is certainly something that could be considered. And then even more inotropes. And I'm not very good at the micrograms per kilograms per minute type things, but we had adrenaline standard dosage for RFDS over in there, which is 4 milligrams and 50 mils, and NORAD at 4 milligrams and 50 mils, and they were both going at 100 mils an hour, trying to get a blood pressure. And that means that each syringe pump driver lasts half an hour. And so we flipped over onto double strength of both, and ran them at 50. And we're getting all these side effects. We're getting atrial fibrillation. So I think we've maxed the inotropes. So I don't think we could have done anything else there. But she's still got no blood pressure, and we've given her a thrombolytic. Maybe she's bleeding somewhere and she's got a biopsy. So we had a look at her belly with the ultrasound, and there was fluid all the way out all the way through her belly, and I thought, oh God, we've given her a bleed. But obviously I've forgotten that she's got nephrotic syndrome, so actually she had ascites. And when you look at the right kidney in more detail, there was no evidence of a hematoma at all. And then we thought, well, should we do it again? Got nothing to lose, let's do it again. So we did it again, we gave her a full dose, and did it work? No. So the pH is still less than 7, or I've probably got red things around them. Yeah, PCO2 is still over 110. So she's on her way out. So given that, what do we do now? It's a bit sad, I have to say. I've got a parent in the waiting room, sorry, in the relatives room, that hates me even before I started this. And now I have to go and grab all the relatives and bring them through for a last visit, and they all kiss her and say goodbye. We updated our FDS. They've been tasked, and they will be there in about 20 minutes' time. And one of the things I didn't realise about our FDS was that if you load a patient into a plane with no blood pressure, they go head first towards the front of the plane, feet towards the tail of the plane, and as they accelerate the plane down the tarmac, the G-force makes all the blood rush to their feet. So if you've got no blood pressure, they arrest. And if they manage to survive that bit, when the plane starts going up in the air, gravity will do the rest as well, and they're bound to arrest. And so the coordinator said, well, look, the plane's there in 10 minutes or so, but this girl will not survive. She won't survive the extrication. We found ICU at our receiving hospital, Charles Gardner, and they were incredibly supportive. They ran through all the things that we'd done and said, yes, well, you know, you've done everything that you can possibly do. You shouldn't feel bad about this. For some reason, someone phoned a respiratory consultant, and they phoned cardiothoracic surgery because, you know, the treatment now is the only thing that she can have is a thrombectomy on bypass. And their line basically was, you get her here, we'll take her straight to the theatre and take the clot out. So we packed her into the bus and drove out to the airport, and 140 k's an hour, got there in 10 minutes, and then had the speed bumps. So it was fascinating. Over the speed bumps, there must have been some mechanical dislodgement of clot. And her blood pressure was suddenly 200. And we dialed back the inotropes, and she was on next to nothing and flew off to Perth. And at Sir Charles Gardner Hospital, she went straight from the ambulance into theatre. She had a thrombectomy on bypass. She was extubated on day 2. She had an acute kidney injury and spent 3 or 4 days on dialysis, but then it was weaned off and it went. And she was discharged on day 9. Back to the And when I got back home, one of the guys that worked there sent me this text and saying, just had her name back in with transient AF, full recovery, stenotomy and thrombectomy, but intact, walking, talking, looking well, just thought we'd like to know. I'd flown off, not having transferred her, thinking that she'd died. So, a few reflections on this. Now, sometimes it's keeping worth going on resuscitations. I think that I'm one of the emergency physicians that is close to 2 standard deviations from the norm about stopping resuscitations. Most of the time, and I know it's just the job that when people come in and they've got a resuscitation going, that we've got to sort of try and keep going. Well, I just say, no, just stop. It's been 20 minutes. out of hospital cardiac arrest. They've got fuck all chance, they're dead. And I'm open to criticism for that. But this girl was young. We never lost the carotid pulse. We had no other pulses, but we never lost the carotid pulse. Somehow she managed to skirt the evils of cerebral hypoxia and end up with a normal quality of life at the end. And I think that just demonstrates with young patients just how amazing their physiological reserve is. And so for me, it's been a wonderful reset on my approach to resuscitation in young people. I mean, I'm still pretty brutal about the old patients. So that's it, really. I've retained my love of rural medicine. So despite having moved back to Brisbane and working in a big central teaching hospital, I missed it. You know, the time that you spend arguing between a respiratory registrar and a cardiology registrar what the BNP is so frustrating that it's wonderful to go back out to somewhere where you're it, you make the decisions, you get on with it. And so I found that in Mount Isa Base Hospital. Same grade pathology is great. Really well paid, that helps. And it's a bit closer to home. When they talk about people that go to these rural places, it's described as the 3 M's. You're either a missionary, because you want to go and help people. And there's a lot of disadvantage, there's a lot of Indigenous help. You're either a mercenary, you go for the pay. I think I've declared my interest. Or you're a misfit, and maybe I'm a little bit of one of those too. Lastly, you've got the leaflet in front of you. I've got the pleasure of running a conference just next month, in fact, or 2 months' time, with Quentin and Dylan. So if any of you like rock climbing, come and join us in the Blueies. Thank you very much. And do we have any questions that I can answer? Any questions? Yes, good.
Yeah, great talk, Charlie. Thank you very much. Why did the dad think she may have had a PE?
He'd been warned by the renal team that one of the biggest, worst complications from nephrotic syndrome, an exacerbation of nephrotic syndrome, is it's profoundly procoagulant. So, you know, and then, you know, being given the information of what does a DVT look like and what does a PE look like. And so therefore that was his assumption. Yes, at the back.
I'm just interested to know if the medicine registrar wasn't there to do the ultrasound, would you have proceeded to thrombolyse the patient?
Yeah, great question. Yes, and the other question that sort of basically comes from that is, would she have got thrombolysed quicker? And I think the answer to that is yes, also. I was definitely hesitant. I've never thrombolysed a massive PE before, and I was hesitant about it, particularly with no diagnosis. You know, giving someone a thrombolytic is scary. You know, I was so happy with the team that I had that day. That, you know, they're really good. Other non-specialists, but, you know, good senior doctors, medical officers, who were highly supportive the whole way through. Because you know, I got rattled. I got rattled. Yeah. Any other questions? All right. Well, thank you all very. Oh, one more. Sorry. Go on.
Just on a point of etiquette, Charlie, who is acceptable to call the Ginger?
You're a Tim Minchin fan, are you? All right. Well, thank you very much. I hope you enjoy your last night here tonight, and have a great evening.
All right, just bear with me one moment as I pull up our excellent photo submissions here for today. And let's hear it one more time for Charlie for that excellent presentation. I don't think I've ever been so stressed before during a presentation. I was like, oh, she's going to die and I'm going to have to stand up here later and be like, let's all laugh at some photos. So I'm really glad I had a good ending. So thank you once again. So we all know what we need to do. The loudest noise or photos or videos with the loudest cheer will win a prize. We're prizes today. First prize, $100 for Dan Murphy's. Second prize, $50 for Dan Murphy's. So yeah, it's a one size fits all. There's about 7 or 8. So yeah, polite golf claps if it's not your favourite. But yeah, some good ones up there tonight. So let's get started. Yeah, that's a nice one. That's the...
It's 8:30 till 9 o'clock every night. It's very pretty.
Did mention your name to get a discount? Or? Yeah. Yeah, it's cool. Oh, that's a good one. Classic Snow Angel. Another video here. I love the ones with the good leading because you always know something bad's going to happen. Oh, there we go. Representing the Rider Hero t-shirt. Mount Yotai in the background there for all those who got a chance to see it over the last couple of days. Oh, I felt that. Bit of fireball on the slopes. All right, any children in the audience, probably time to look away. Not super clear, but he is nude. I just feel for this poor person here that had quite the view. Oh, whoops. Oh, we'll see it again. Why not? Does anyone want to own up to that being them? Oh, yeah. Stand up so everyone can see. Go on. Stand up. All right, another photo. All right, I think we might have 2 winners there. So I reckon $100 voucher for the spread eagle. And I reckon $50 for the very brave girls there in the picture. So yeah, let's hear it again for everyone who submitted some photos. So just in sort of closing, I'd just like to say a few thank you and wrap everything up before we head out tonight. The closing function is a very informal event. There'll be no speeches, nothing like that. So it's the last time you have to hear from me, so that's good news for everyone. So this year we've been very fortunate to be in a position that we have been able to start giving back to organisations that are close to our hearts and also close to other participants' hearts. And so our goal for 2023 this year is to donate $9,000 to Beyond Blue. It's an awesome organisation and all your registrations help us be able to donate that money as well as the contribution from Everest Wealth. So it's something that we're going to do each year moving forward. So if there are any other organisations out there that you guys would like to see us support or see your registrations go towards, please send us through an email, let us know what they are. Certainly in 2024, we'll be looking to sort of increase this amount and give back even more. So, had to see it again. So I guess in more exciting news, we will be back here in Rusutsu, and just yesterday we got confirmation that we can actually run a second conference. So yeah, it's really awesome, and thanks to everyone's support for coming to these conferences and spreading it by word of mouth. So we will be here twice. The conference week will stay exactly the same, no changes there. We're just going to be doing it 2 weeks in a row. So any help from everyone here today in spreading word when you get back. We've got lots of flyers we can send out to you, so make sure you hit us up if you've got a good spot that you can hang a flyer up. But yeah, we'll be here end of Jan, and then once again sort of Jan into February to, I guess, try and keep this going and get a 2-week snowboard trip really for us. So yeah, we're certainly not complaining. Our prize sponsors, so as you can see, all the businesses up here have done a great job throughout the week sponsoring our prizes for all the photos that have gone in, so thank you to them. And also let's do one round of applause for all the presenters as well, because they've been awesome. Last up, and I guess the most important one, our biggest thanks is to each and every one of you in the room here. So we started the idea back in sort of 2014, 2015, working on road as paramedics and kind of thinking what's a good sort of excuse to be able to keep coming back to Rusutsu year in, year out. And the answer was, let's do a conference. If we can get 10 people, it's tax deductible and we can get a trip out of it. And so over the years, it's continued to grow, but none of this would be possible without all your help. So pretty much, yeah, from Dylan and myself, thank you so much. We hope to see you all again at later conferences. Please hit us up if you do have any questions. We'll be sending out a survey form tomorrow morning. It's all scheduled to go because I'm not quite sure how good I'm going to be in the morning to be sending out emails. So there's a link on there. Please be honest with your feedback. Each year we do want to continue to improve and grow these events. So please make sure you put your details, or you don't have to put your details if you don't want to, but put your thoughts, feelings and anything else, and we definitely take those on board. Apart from that, stay safe, look out for each other, safe travels home, and we'll see you all again soon. Cheers.